Welcome to the webinar, Integrating Harm Reduction into Tobacco Control in Nigeria and Kenya, saving 600,000 lives in these two countries. So thank you for joining today's discussion on a vital public health issue. The report we're examining today, which has been launched, called Saving 600,000 Lives in Nigeria and Kenya, highlights how targeted tobacco harm reduction strategies, coupled with better lung cancer treatment, have the potential to save lives and reshape the tobacco control landscape in both of these countries. Now I'm going to go over the agenda briefly. So today's session will begin with an exploration of why Nigeria and Kenya are the focal points for this research. With 38,851 premature deaths each year due to tobacco use, the public health and economic impact of smoking in these countries cannot be overstated. Both nations present unique challenges and opportunities for tobacco harm reduction, with data indicating the urgent need for innovative strategies beyond traditional tobacco control. So our keynote speaker, Dr. Derek Hyach, the principal author of this report, will provide an overview of the study's rationale, methodology, and key findings. Dr. Hyach will also discuss the report's recommendations to policymakers and also address the challenges with regards to how does one give priority to ending smoking in countries with so many other health priorities. We'll then turn our focus to consumer advocacy and community engagement. Joseph Magero, chair of the Campaign for Safer Alternatives from Kenya, will discuss how today's findings can mobilise consumer groups, emphasising the role that a strong consumer voice can play in advancing tobacco harm reduction at the government level. Next, Uche, CEO of CASA from Nigeria, will highlight the potential of religious leaders to act as powerful advocates for harm reduction within their communities. He will address how governments can support religious leaders in spreading awareness about tobacco harm reduction, making cessation more accessible, and ultimately accelerating the decline of smoking rates. Finally, we'll conclude with actionable steps to ensure this report's findings are translated into impactful policy and practice, paving the way for a smoke-free future in Nigeria and Kenya. Thank you for joining us in what promises to be an insightful discussion on the critical role of tobacco harm reduction in saving lives and improving health outcomes. I would now like to introduce Dr. Derek Hyach to deliver his keynote speech.
Thanks, Jessica, and a real privilege to be able to share this data with you all. And at a time when we know we seem to be turning the corner on countries giving greater support to the value of tobacco harm reduction in the face of what have been years of neglect. So as a background, I think the reports on Nigeria and Kenya are significantly different from many others from advanced industrialized countries in a couple of ways. First, the level of competing priorities in the health sector are substantial. And what the reports show that many people fully realize is that the dominant forms of causes of death, disease, and disability in both Nigeria and Kenya remain many of those we associated with a lack of development, a lack of basic infrastructure, access to health services. And so it's not surprising that things like malnutrition, water-related deaths, HIV/AIDS, casts a very strong role over all of the mortality and morbidity. Why that's important is because it can mask what's going on below the surface, as the risk factors for chronic diseases are rising everywhere in the world. So is the same with tobacco. So if we look at Nigeria, country, one of the most populous countries in Africa with over 200 million people, and Kenya with about 50 million people, we see that they both have smoking rates which are relatively low. Kenya about 10%, where the male smoking rate is almost double that, and the female smoking rate is under 1%. And Nigeria, the overall smoking rate is now under 5%, and has always been under 5%, with the female smoking rate being 0.3. Um, Despite those very low rates, there are substantial proportion of deaths caused by tobacco that could be and should be prevented. In the case of Kenya, about 12,000 people die a year because of tobacco use, and in Nigeria, about 26,000. We undertook this work to look at what could be done to accelerate a removal of these causes of death, particularly in the face of them having so many other competing priorities. Why would you want to pay for the costly expense of lung cancer, cardiovascular disease, at a time when the costs of meeting the needs of malnutrition, TB, and HIV/AIDS have not been fully met? So we used a standard methodology that's now been tried and tested in many countries and builds on the work of many folk in the public sector and in the private sector, and really asks the question, how many lives would be saved beyond those that are likely to be saved if WHO's current strategy, which is based on taxation, a range of regulatory approaches, unfolds over time? And what we showed is that if we were to add tobacco harm reduction to the mix, which is currently not the case, the WHO projections of about 18,000 deaths a year by 2060, down from 26,000 today, would be cut down to 11,000 with if you added tobacco harm reduction. And if you improved cessation along the way, you'd be down to about 7,500 deaths a year. So 18,000 WHO projects, we're saying you could get it to below 8,000, a substantial number. In Kenya, the equivalent figures are that we have 12,000 deaths a year in 2060 projected, and those figures will go down to 8,000 by 2060 if WHO's approach is followed, but they cut well down to 3,400 a year if we apply cessation and harm reduction. Now, that's a lot of numbers to throw to you, but if you put it into context, it means 600,000 lives will be saved in Kenya and Nigeria by applying tobacco harm reduction programs and better cessation. Those are 600,000 more than what WHO is projecting. So given that that's such a huge figure, the question is, what is it that one can do to get on track? And what is the state of tobacco harm reduction in both of these countries? The report lays out many of the reasons why we're seeing slow progress, and I won't go into them. But I would say just one thing, that the evidence on the benefit of tobacco harm reduction grows by the month. We've had solid evidence about the effectiveness of vaping as one of the most powerful means of quitting cigarettes for many years. We have seen reports from Japan showing that half the male smokers have now switched to heated tobacco products, and that it's extremely likely, based on evidence, that that will dramatically lower their mortality rates. We've seen from Sweden, Norway, Iceland, dramatic increases in the use of snus and nicotine pouches, which are showing great relationships and have been for years with some of the lowest cancer rates and cardiovascular disease rates in Europe and, in fact, in the world. All to make the point that these harm reduction measures, whether you're using nicotine pouches or you're using heated tobacco or you're using vapes, they all substantially lower the risks that would be associated with the use of combustible cigarettes. And remember that particularly in Kenya and to a lesser extent Nigeria, there are added factors, the use of toxic smokeless tobacco products, many of them originated in Asia, are a major cause of oral cancer in those countries. So we believe that the application of these needs to start urgently. And the place they could start and should start, frankly, is in the very large publicly financed programs of PEPFAR, the US government's largest program in the world addressing HIV/AIDS, and in the Global Fund on AIDS, Malaria, and TB's programs, both of which are very strong and very present in both Kenya and Nigeria. The important thing to remember is that in the case of AIDS and TB, we know that a substantial proportion of patients with AIDS and TB smoke. And yet, within the large public programs, there is no provision made either for smoking cessation or for harm reduction. That's a place to start. It would be highly cost effective. It would save the lives of people who are going to be put onto costly HIV/AIDS and TB treatment and ensure that they don't go on to die of lung cancer and cardiovascular disease. Finally, I would say that one of the challenges is how do we address the fact that women in both countries smoke at extremely low rates, under 1%? For, for those countries and for many around the world where women are smoking at such a low rate, we really need to think far more innovatively about how women could become the exemplar for all women worldwide about what the accepted norm should be. A smoke-free nicotine future for them is a reality today. We need to do everything from a policy point of view to ensure it remains that way. And that would include ensuring that companies and the public sector recognize the fact that we do not want to see smoking or, in fact, the use of any nicotine product increase in populations where they are non-existent today.
I see you mentioned other health priorities that these countries have. So could you just summarize again in your own words, how do these governments in Nigeria and Kenya give priority to ending smoking when there are so many other competing health priorities?
Many years ago, I won't say how many because I was 12 at the time, I did a major review on smoking in Africa and asked the question, what are the additional risks that we ignore in advanced industrialized countries that developing countries, particularly those in Africa, suffer from? And in the case of Nigeria and Kenya, we know that high rates of HIV/AIDS and tuberculosis are among the most dominant concerns in terms of mortality, premature death, and so on. What is not spoken about enough is how a significant proportion of TB deaths would be prevented by actually not smoking in the first place or using reduced risk products in the first place. And certainly, we need to ensure that given the fact that the majority of TB patients will be smokers, they need to be given access to the most effective means of quitting, which is now harm reduction products. The same is true to a less extent of HIV/AIDS. There are other issues in Africa, high levels of cancers that we don't see as much in the West, cancer of the bladder associated with parasitic infections, where smoking seems to increase their risk. Esophageal cancer, one of the commonest causes of cancer deaths across Africa, where smoking and also contaminated forms of food are major causes. All to say that tackling smoking simultaneously with addressing those other risks makes complete sense from a public health point of view. We have long known that we don't have the luxury of saying we're going to focus on disease X, Y, and Z and exclude others when you have no way of knowing what an individual is actually going to suffer from. You need to take a holistic perspective. And in that holistic perspective, putting harm reduction on the list to eliminate and reduce dramatically the causes that are driving smoking would make a huge difference.
And you mentioned that the smoking rates between men and women are very different. We know that women smoke a lot less than men in these two countries. But what does that mean for policies, do you think?
I think we have a lack of a public debate globally around what should be the right policy in countries where the smoking rate among women is under 1% or under 2%. It's very clear that even though the male smoking rates are higher, they anywhere between 10 and 20% in Nigeria and Kenya, the standard approach applies. Throw everything you can from a tobacco control policy, make sure that harm reduction is targeted explicitly to those groups. But in the case of women, the question of how you address it in a way in which you're sensitive to the needs of women and the reality of not wanting to see smoking, and I would say nicotine use rise, is something that neither the public sector nor the private sector has devoted enough time to. And instead of giving a simplistic view of saying, well, we should prohibit all sales of cigarettes and vapes and harm reduction products to women if the smoking rate is below 1%, we know that that prohibitionist approach will fail. So, what is an alternative way? We don't want to go the route of youth access and over kidifying the way we've been doing it on kids. How do we turn things around and rather argue that women should be seen as the leaders of where we want to be in the future? The voice of women need to be strengthened. The role of a smoke-free world starts with what women are doing today in countries like Nigeria and in Kenya, and I might add Ethiopia. But frankly, across most of the low middle income countries, we have smoking rates below 1 or 2%, including in China and Indonesia and many other parts of the world. All to say that there's no simple answer, but it's a debate that has been long out there requiring substantive discussion. I would add one point that when I started the work with Dr. Brundtland on the Framework Convention in the late 1990s, the very first meeting we hosted was with the Japanese government in Kobe, Japan. And the topic was entirely devoted to the question of women and smoking. How do we address this in a way in which you empower the women's movement? Sadly, that never happened. And even though there are strong gender provisions in the Framework Convention, the women's movement have never taken up the issue of smoking or harm reduction as a substantive issue that they should be putting all their efforts behind.
And finally, before you go, just one last question. I'd love to hear your thoughts about the role of health professionals and physicians, because surely they're crucial to bringing about any change.
Yes, I think, Jessica, that my own view based on hard experience is that if the physicians and the health leaders of the country are not behind policy, you don't have patients getting the best advice and you don't have governments getting the best policies. And I think in Africa, we have an added opportunity, and that is the vast use of traditional healers. So I would say when I'm speaking about physicians, I'm also talking about the role of traditional leaders and in some places, faith-based leaders, all being a potential powerful voice who reach their community on a very regular basis. If they were to be turned on to the value of harm reduction and ending smoking, I know that we'd be able to amplify the voices, particularly through their ability to reach people in communities without having to go to health services where the costs are exorbitant. So yes, having them on board early, strongly, all the time is absolutely vital to the success of ending smoking.
Thank you, Derek. And now I would like to welcome Joseph Magero of Kenya. Congratulations, Joseph, for co-authoring this report on the impact of combining tobacco control with tobacco harm reduction in Nigeria and Kenya. And the report's main finding is that over 600,000 lives could be saved by 2060 through smoking interventions, compared to continuing with current WHO-directed tobacco control efforts alone. So, Joseph, can you comment on the report and its significance for these two countries?
Thank you, Jessica. Well, so the LifeSave report highlights the potential of THR strategies to prevent thousands of smoking-related deaths in Kenya and Nigeria. It basically emphasizes the need for policies that integrate safer nicotine alternatives to traditional cigarettes, following examples from countries with successful harm reduction models such as Sweden, where smoke-free products have drastically reduced smoking rates and associated health risks. So the report focuses on Nigeria and Kenya, where we have about 38,000 plus deaths every year because of smoking, and it demonstrates how policies that promote less harmful nicotine products could reduce this burden and potentially save up to 600,000 lives in both countries.
So which products are permitted for use in Kenya and which are not?
So at the moment, nothing is illegal, but policy-wise, it's a bit of a gray area as the products are very new in the market. So what we have is policymakers trying to adjust the current laws so they can accommodate these products. They're legal in Kenya and Nigeria, both snus and nicotine pouches at the moment.
So are the Kenyan government wanting to ban anything in the short to medium term?
Initially there was talks of banning, but the direction which they're taking now is to regulate them. same as tobacco products, which means the tax levels are the same and the labeling is also similar.
Because is it not true that currently the oral nicotine pouches have a graphic health warning the same as cigarettes, or has that not come into force?
It hasn't. That's what they're trying to do at the moment. So the laws haven't been passed yet, but they're in the Senate right now.
And as somebody who leads a consumer platform in Kenya, which is CASA, Campaign for Safer Alternatives, and you also have expertise and qualifications in public policy, can you speak about the findings of the report and how they can be used by both groups, as in both consumers and policymakers?
I mean, 600,000 lives is quite significant. I believe that policymakers can use these findings as a blueprint and use the report as a guide when formulating policy. In terms of consumers, consumers can use these findings as evidence base when arguing for safer nicotine products, and also demonstrate to people who smoke that there's other products that are less harmful for your health, and you can live healthier by switching from traditional cigarettes to these products.
And how can we get these messages across to both consumers and policymakers? I know you have lots of experience in this area, but how do we get them to listen to the messages that we're trying to convey?
Well, we can use different methods. We can use traditional media, we can use social media, we can use awareness campaigns, and also some forums that we have where we invite both policymakers, medical doctors, and other groups, health groups that are interested in such subjects, and share the messages as far as we can.
Okay, so and as consumers should have an important seat at the table as they're the ones using and benefiting from these alternative smoke-free products, how can we strengthen consumer representation at the government and the policy level? How do we bring those two groups together so they can have a dialogue?
Initially, I believe the first step is to establish formal consumer advocacy groups, as many as we can, and also by engaging in public consultations and comment periods whenever they arise. Also, data and research-driven advocacy is quite important. It's a tool we can use. Building alliances with public health and medical profession is also a method we can try and interrogate. And lastly, seeking support from legislators and policy champions, because there are some legislators who are interested and are keen on THR.
Thank you, Joseph, for highlighting the importance that a strong consumer voice can play in advancing tobacco harm reduction at the government level. Now I welcome Uche of Nigeria, who will discuss the role that religious leaders can play in spreading awareness of tobacco harm reduction and making smoking cessation more accessible. So hello Uche, congratulations on the Lives Save Nigeria and Kenya report and welcome to our launch. It's a real pleasure to have you here with me today. You are an author and project manager at THR Nigeria, and tell us about tobacco harm reduction in Nigeria.
Thank you very much, Jessica. It's a great opportunity to be here, and thank you for the congratulations. Back home here in Nigeria, tobacco harm reduction has a long way to go in terms of communication. There's really a huge gap in terms of knowledge in different sectors, starting from the grassroots, and also the knowledge gap with medical practitioners. Because 2021, when we had a research done, we found out that over 67% of health professionals in health personnel in healthcare, they do not have a good understanding of tobacco harm reduction policies. They understand the basic of harm reduction, but when it comes to tobacco harm reduction, they have the frontliners in health sectors, and we're talking about public health generally. These people are the set of people that we want to believe should be armed with the right information. Unfortunately, this set of advocates do not have much information on their hands, so there's a knowledge gap on that, and which is also crossing the bridge in the public knowledge generally onto the grassroots, and it's really affecting tobacco harm reduction in Nigeria. But what we are trying to do in tobacco harm THR Nigeria is to create an unbiased platform where we would have sufficient and accurate information for the public decision. Currently, there are some smoke-free products that are being used in the country. Unfortunately, they are not prohibited, neither are they allowed, or per se. What I mean is there's no regulation, there's no prohibition or a nod from the government. These smoke-free products are generally in use, but there are no policies, no control, no regulations currently in the country. So we currently have nicotine pouches, the oral nicotine pouches. We also have vaping products, the electronic cigarettes. We have snus, which is not commonly used. So what is commonly available that you see around is the vaping products, that is electronic cigarettes, which is commonly used around us. Yeah, then very few persons uses the nicotine pouches. I've come across a few persons buying them from some of the vaping stores and using them at the club as well.
So you think that the most popular smoke-free product is the vaping products, not the oral nicotine pouches or the snus or the heated tobacco products?
Yes, exactly.
Interesting.
Unfortunately, I think it still boils down to a lot of awareness. We need to keep the conversation going because a lot of people do not know that there are other smoke-free products beside electronic cigarettes, that is the vaping product. So there need to be a lot of awareness and communication to the general public so they can know that there are other options for them.
Who do you think should be driving this awareness to the general public? I mean, how do you think this should be approached?
Mostly organizations, consumer advocates like THR Nigeria in Nigeria and THR in Kenya, and generally mostly consumer advocates, because I believe we are independent individuals that our informations are basically our experience and based on the informations that we've gotten from the researches that are unbiased. So I think we are the ones that should be pushing this information. Also, the media can come in based on individual stories, especially for nicotine users that have switched already, because when you tell your personal stories based on the smoke-free products you've used, if it's on snus, if it's on vaping products, if it's on oral nicotine pouch, you're able to tell the story by yourself and tell your experience. That can never be invalidated.
Yes, absolutely. Consumer testimonials are always some of the most interesting. You can form a connection with people improving their health. It's more emotional. So I think that's a good way to get to policymakers as well, to show these positive case studies of people who've actually improved their lives and showing those details. So regarding the report then,
You're right.
can you please provide us with your insights on this report, which found that 600 lives could be saved by 2060 if both the Kenyan and Nigerian governments embrace tobacco harm reduction. So your ideas and insights would be great.
The highlights for me and my insights to share is that it is the readiness and the potential of tobacco harm reduction when it is fully embraced in fullness, which I believe is going to help reduce smoking-related diseases and reduce and lower the death rates and improve the life of Nigerians generally. So we also need all sectors to be involved. And when I mean sectors, I'm talking about government officials and decision makers in the country, and also public health practitioners. So until we are ready to embrace tobacco harm reduction policies in all fullness, that is when I believe there's going to be an impact, just like how the report has stated. It's important for us to work together collectively to achieve this goal.
Absolutely. And one of the recommendations in the report mentions the role of religious leaders in tobacco harm reduction. So, how do you think religious leaders can create an impact when it comes to harm reduction in their communities?
Honestly, that has to be one of the toughest discussion I think I'm going to be having going forward with other advocates and other comrades in the community, because Nigeria as a country, we are conservatives, and it's going to be a very hard call to involve religious leaders to advocate. Okay, left alone, they won't advocate for you to start smoking when you're not, and then they getting involved asking you to switch to a less harmful product might be a very difficult call, because as I mentioned, that we are conservative people here, not to mention adding that you're also a religious leader. It's enforcing it is not going to be easy. But then I believe this is a conversation that we need to keep open, and then keep finding way on how to get the religious leaders involved. From the reports, found out that research was done in Jordan and in UAE, countries like that are Islamic countries. I want to personally believe they are liberal in their practices, but here in Nigeria, from the experiences, they are very conservative, and permit me to use the word, we have extremist extremist Islamic practices here. So that might be a very difficult conversation to engage in, but then it's something we can keep open and keep discussing, and keep dialoguing around it until the impacts are made.
But do you think that governments could actually support these leaders better to encourage smoking cessation or smoking abstinence or a switch to reduced harm products? Do you think governments can train or support these religious leaders better?
I believe so. The objective, the goal generally is to help people quit smoking. So, and in tobacco harm reduction, where you find it hard for you to quit smoking, we advocate for you to try other less harmful products. So the goal is for you to quit smoking. So I believe governments will readily available or will be interested in training religious leaders on issues like this, so long as its aim is to cause smoking cessation or reduce the impact of the diseases caused by smoking. So I'm sure the governments are very open to this, and I'm also sure that the religious leaders will be open to such conversation. Um, the reason why I thought I made reference to conservative practices is because the Islamic communities, they uphold their holy period, the Ramadan period, as a holy period, and from anything that has to do with what they call haram, they frown at it seriously, and they consider smoking as one of them. So having such a conversation with people that you are not sure if they are smoking or not. So the only way forward is to identify these persons that smoke in the religious body. But then we need to also consider that some persons might be pretentious, wouldn't want their religious leaders to know that they are doing these things, and then which is also going to cause a setback for us as advocates as well. But in all, I want to believe this conversation is still, it's something I think we should keep discussing and finding ways around it until the goal is being achieved.
Absolutely, well said. And are there any final points before we finish the conversation today about the report or THR in Nigeria and Kenya?
I'm mostly impressed that we highlighted the actions to be taken in the reports, which particularly is the part where we need to inform health practitioners like I mentioned earlier, that there's a huge gap in that area, particularly in Nigeria. And I'm hopeful that as this report is being launched soon, we would channel more effort into those actions, those key client actions, and put more effort and focus on them to be able to achieve more goals.
Thank you very much, Uche, and it was a pleasure to have you here with me today. Thank you, Uche, for your valuable contribution. In closing, the report has highlighted the significant potential for tobacco harm reduction to save lives in Nigeria and Kenya. But achieving these outcomes requires coordinated action on several fronts. Key next steps involve mobilising health professionals to communicate the benefits of tobacco harm reduction in all clinical settings, dispelling myths about nicotine and advocating for harm reduction. Governments must pursue risk-proportionate regulations that increase access to less harmful products and invest in local tobacco harm reduction research, while enforcing stricter controls on cigarettes to support healthier choices. Strengthening consumer advocacy is also essential. Independent science-based groups can champion tobacco harm reduction progress and ensure that public health policies reflect the needs of those affected. Finally, engaging religious leaders as advocates for tobacco harm reduction in their communities will further support efforts to reduce smoking and prevent tobacco-related disease. By embracing these recommendations, Nigeria and Kenya have the opportunity to lead in tobacco harm reduction, drastically improving health outcomes and advancing towards a smoke-free future. Thank you for joining us today to discuss this transformative approach. The report is available on thr.net under the Resources tab, and you can also follow our social media channels for more information. And lastly, a very big thank you to the international authors who contributed to the methodology and assumptions of this report. Thank you for listening.